go with our next question, which kind of builds on what Jennifer was just sharing. And it's, what untapped areas of intervention or unanswered questions in practice or research could we address to help advance equity in men's mental health? So that idea of where can we go from here? And maybe, can I pick on Sarah to go first this time?
Sure.
I'm not being very consistent, I'm sorry. It's a gamble.
So an unanswered question that has arisen from my work, and it builds closely on the work being done within the cluster on men's access to mental health services, is what is the extent of income-based inequities in access to services? So here in New Zealand, we had a government mental health inquiry, and what they found is, despite having a publicly funded mental health system, there was a large amount of unmet need, particularly for psychological therapies, and we have a shortage of clinical psychologists here in New Zealand. And I think New Zealand is similar to Canada, where we have this two-tier system for psychological therapies, where those on lower incomes who don't have access to employment-based benefits or can't afford to pay for out-of-pocket therapies are more likely to have unmet needs for mental health services. And I found this in my own work. So in my PhD, I interviewed men who were often in fairly well-paid jobs and accessed psychological therapies through workplace employee assistance programs. And although a number of them complained that 3 funded sessions wasn't enough, it was often enough for them to try out for the first time, but also for them to find a therapist that they felt they had a good fit with. Then they could go on and pay out of pocket to continue accessing those therapies. Whereas in the current work that I've just finished, the majority of men that I spoke to couldn't afford to access services, couldn't access publicly funded services, and had no access to workplace assistance programs. So really clear income-based inequities in access to services. In terms of areas for intervention, an area that's become not an area I thought I would delve into, but a number of the men in my photovoice work have talked about trauma, childhood trauma, adolescent trauma, and lack of access to care despite experiencing significant trauma that has led to repeated suicide attempts. So I think there's something there that we need to look at, trauma-informed care for men and what this might look like. Here in New Zealand, there is some access to trauma-informed care through our government agency called ACC, which is Accident Compensation Corporation, and it's very unique to New Zealand, and it covers comprehensive coverage for injury, and within that they cover sensitive claims for sexual abuse or sexual assault. And so I spoke to a number of men who had been diagnosed with PTSD, had accessed services, trauma-informed services through this specific pathway, and actually ended up with access to ongoing treatment, which they would never have been able to afford themselves. So I think there's something there about trauma-informed care. So those are some ideas.
Great ideas, thank you. And then Francine or Jennifer, either of you?
Sure. I'll jump in. Building on Sarah's last point, looking at trauma-informed care, I would say a lot of the research I do and a lot of the programming we developed is around trauma and violence-informed approaches to physical activity. one of the things that I've been thinking about a lot lately, and pitching maybe to Sarah, maybe to all of you here today, but I've talked to John a little bit about, is, merging sort of a masculinities approach with a trauma and violence informed approaches to mental health supports and provision. Maybe some folks on this call know, work that's happening in that area, but I haven't seen a lot directly sort of, examining or taking that masculinities lens to the current, tenets of trauma and violence informed care. So thanks for bringing that up. I think that's a really interesting direction to go in. I think, again, based on the work that I do, I think that there are opportunities in the area of perinatal depression and anxiety, and mental supports, particularly for equity owed fathers. So again, I think in general, it's a field that's maybe picking up, but I think we are sort of, we are continuing to exclude those groups that are the most highly marginalized. I think, further examining institutional policies and funding structures to understand how we can better engage under-resourced or equity-owed fathers with services. I think in some of the work we've done, we looked at family-centered organizations and how they included fathers, and very few explicitly, mentioned fathers within their policies. So I think, again, sort of, inadvertently or not, purposefully excluding that group. So I think, paying particular attention to language that's developed that is guiding organizations. Yeah, and I'll leave it there. I'll pass it off to Jennifer.
Great, thank you. Well, spoke to previously, but another area is implementation science. So several of our projects are hybrid clinical trials and implementation studies. So we test clinical outcomes along with different pathways of care and things like cost effectiveness and reach and other implementation outcomes. And for those on the call who are into implementation scientists love their frameworks, but surprisingly, gender is not really included in any sort of framework. So there's acknowledgement of the importance of the outer setting, what's called the outer setting, which is sort of where the patient resides in many of these frameworks, but not specific attention to gender. And it's such, as we know, as care and mental health seeking, service seeking, and all sorts of things. So I think that's a big untapped area. Maybe we can, interested people on this call, we can create another framework that includes gender and add this to the literature. The other thing that we've been working a lot on, both in Mozambique and New York, is the use of technology. So my role with the Mental Wellness Equity Center is the Director of Technology Development. We have several studies underway, all community-based projects, 2 studies with youth and 1 with adults, thinking about, together with youth advisory boards and community partners, how we can develop technology to improve access to care. And it's very difficult to get mental health care in New York City. And this is especially true for racial ethnic minorities. So a big focus of our project, all of our board, we have racial ethnic minorities on our board. And a big purpose of it is to provide care with using, digital interventions before, or helping people get connected to care in some way. And connection to care is especially difficult for youth. It's very difficult even for adults in New York. Many therapists now don't take insurance because the pay is too low. I mean, there are lots and lots of issues. And for a session, it could be $300 to $500 a session. So really inaccessible, I would say, for most of the population. So just considering and continuing to brainstorm, work with communities, and understand how we could potentially leverage technology to support care.
Amazing. Thank you so much, and to Francine and Sarah as well.